people are attending this webinar. First of all, I would like to say Assalamu alaikum, everybody. We are today in a webinar meeting that will focus on digital healthcare and the transformation that's happening, especially at this era with COVID-19. I would like to thank the organizers, special thanks to Dr. Osama Hassan and his team at the United Arab Emirates for having us here with him. And first of all, my name is Salman Al-Sabah. I'm a surgeon and also I'm an assistant professor at Kuwait University in Kuwait, and with an interest in digital healthcare. And we've been working on digital healthcare for the past few years and how we can improve our platforms in the GCC area. It's always a pleasure to see our colleagues from and brothers and sisters in the GCC area, and we look always to work with them and improve our platforms, the digital platforms in this region. With that, I would like also to welcome our speakers, and we have today Dr. Brown, and she's a medical director, Northwell Health Solutions from USA. We have Dr. Abdullah Raghdi, Director of General of Information Technology at Ministry of Health Oman. We have Dr. Abdullah Sana, Director of Medical Accountability Administration at Ministry of Health Kuwait. And we have Dr. Muhannad Jamil, General Director of Health Supporting System at the Ministry of Health and Kingdom of Saudi Arabia. Please welcome, and we look forward to your presentations. So we're going to start presentation by Dr. Brown, and then at the end of the session, after all the presenters give their talk, which will be focusing on digital healthcare and also in the era of COVID-19, we're gonna have questions. Please use your questions in this Zoom meeting questions Q&A instead of using it in chat, because I will be able to see your questions, and then hopefully at the end of the session we can answer all of your questions. And with that, we can start with Dr. Brown. Dr. Brown, the floor is yours.
Hi, good morning, or good morning in the US, but good evening for the GCC, and thank you for having me today. As you said, my name is Dr. Zenobia Brown. I am a doubly board certified physician in hospice and palliative care and family medicine, and I function as the Medical Director for Health Solutions, which is the care management organization for Northwell Health, and our Vice President of Population Health. Just as a check, can everyone see my screen? Thumbs
yes,
up? Excellent. So I'll just jump right into them because I would imagine a lot of has questions. And really what I want to kind of go through is kind of some of the experience in New York, and then how at Northwell Health we leveraged sort of our population health IT across these different healthcare domains. And really there is kind of the ambulatory or the community domain and kind of the utilization of the technology to really meet the patients where they are, because this is a disease that is primarily happening in the community. I think people are very interested in the acute care setting, and then how do you manage those populations that are in your hospitals. And then there is an entire kind of employee and workforce consideration domain, which is how do you keep your employees who are taking care of those patients connected? How do you keep them connected to their own healthcare? And then how do you sort of keep them sort of mentally healthy, which is an area that many people have questions about, because this is a marathon of a pandemic and not something that sort of happens all at once and then you can just kind of get over it. There is a recovery phase around these symptoms and what is happening with these patients. And then a little bit about analytics sort of sprinkled in. Again, I will try to keep the comments kind of brief because I think there will be a lot of questions, and clearly you could spend hours on any one of these domains. So just a little bit about Northwell Health. It is the first and largest integrated healthcare system in New York State. It is 23 hospitals, 750 ambulatory facilities. It is a school of medicine. It is a school of medical school. It is a nursing school. Over 5 million patient encounters a year. We are 30% of the New York market. We have over, I think that's 71,000. I think that number's even higher employees with over 4,300 employed physicians. We have over 13,000 affiliated physicians, which are physicians who use our facilities and who we have collaborative relationships. We have over 1,800 residents and fellows and 116 graduate medical education programs and 4,000 researchers. We also have relationships with hospitals outside of New York State, so Boca Raton in Florida, all the way to Epworth in Australia. So a very large health system that presents sort of specific challenges around how do you have a unified approach in something like COVID. So I sort of at the HIMSS lecture kind of joked that when I was asked to give a talk on the deployment of technologies in COVID, you know, at that point, I laughed because we were still in our office. So between that point when anyone was asking me to talk on this topic and now, New York State, as everyone on the call knows, has become, or New York City in particular, has become the epicenter of this pandemic. These are figures which are updated as of 5/11, but in New York State alone, over 335,000 cases, 184,000 of those in New York City alone. So you're talking about a tiny geography in many, many cases with over 21,000 deaths. Of that care, we are now, this number is just for the Northwell Health share of the market. So as I said, we are the largest integrated care delivery network, accounting for about 30%, but just in our auspices, you know, somewhere north of, this number is 10,000, probably 12,000 inpatient encounters having to do with COVID. And one of the things that I just will probably reiterate here is that all of that, every single one of those numbers represents what happened in the space of 8 weeks. So when we think about sort of technologies, I'd say the number one sort of take home is that everything evolved. So where we started in this journey is certainly not where we are now and is unlikely to be where we end as all these different technologies mature. Then I think even more you learn what are the technologies you need and what are the best ways to deploy them. So the 4 domains, and again, keep this as you're thinking about kind of your response, thinking about the deployments in these domains. So your community response, how are you deploying technology in your communities, in the buildings, in your hospitals, in the acute care setting, how are you leveraging the different mechanisms to use technology and deploy it, the workforce, which we talked about briefly, and then just a big bucket of data and analytics that we'll kind of get into in these different domains. So community response, this is it's a very busy kind of slide, but I think really the only thing I'm trying to represent here is that this journey into healthcare is very complex and it requires many approaches. So it is not, so one solution there is you will have a great landing page, a great website that has COVID specific information and where patients can get right to testing, get right to a telehealth visit. And that those pathways of who's on the end of those clicks have to be developed. And I think that is one mechanism, but not everybody is going to a web page or getting to your web page. So what does the outreach look like if you're trying to find these patients who you know are going to be high risk? And what is the script around that phone call? Patients who are just calling in, how do you now get those, what ended up being for us, and this really, what you're seeing here is around our call center, but if you're anticipating hundreds of thousands of calls, it isn't just about people answering the phone, but it's what is the, you know, what I'm calling sort of the client management services and data normalization and dashboarding you're going to need to understand how many calls are happening a day, what is the content of that call, what are people looking for, because those are the lessons. That's the, you know, 90% of people aren't employment, what they're looking for is just testing and they're asymptomatic. It's really important to know that that's what it is week 1, but by week 3, you have the opposite, which is people know where to get tested. They're having some kind of medical symptom for which they are looking for care. And then by week 6, when everyone really has it drilled into their heads that COVID is live in the community and doesn't want to go to a facility, even if it's the ED, would rather have some technology come to them. So all of that is evolving, and the ability right from the beginning to be using, whether you're using client management, using dashboarding, getting some sort of normalized data so that you understand how people are using both low-tech technology and your high-tech technology. The other thing I would say for this is, this is just the New York experience, but it's not as though every hospital and in all of New York City, or even within a health system, everybody does everything the same way. So you are going to have different systems of operations, and then even different EMRs that you're wanting to connect so you can understand the patterns and the behaviors of the population. I think chatbots, the request was to just sort of touch on some of the different technologies. So certainly when you have a response in the hundreds of thousands of people, you are needing to deploy technologies that are not humans. We use Conversa. So these are conversational to the patient, in order to deploy kind of education around the disease, around the 4 use cases, sort of screening and triage, lab results, right? So you have tens of thousands, hundreds of thousands of people getting tested. Result is its own bucket of how do we deploy technology to do that, and do that efficiently, do it. And I think there was a question earlier about PHI, or we had an earlier conversation. And one of the things that we understood very quickly was you have to get the consents for these sorts of technologies right up front. So even before you even think you're deploying technology, consenting the patient to communicate with them very liberating later on, even if you don't have the technology when you ask for the consent. And then post-discharge conversations with education and employee sort of screeners. The other sort of community technology is around sort of post, and people are probably hearing, what we know, older, frailer patients, they are susceptible. So how are we understanding what is happening with patients, specifically in this case in nursing homes? So there are technologies that were built around some of these episodes where we would understand how patients in facilities are faring. And this is just an example of using some of that technology to hotspot different nurses, and then also to passively understand patients having, like, they might be COVID. So that technology that integrates you with ambulatory providers, so specifically in this case, nursing home and acute rehab, that exists, and folks might want to take a look at that. And then quickly kind of going into the inpatient, which I will say it's what you can, when you can, where you can, with who you can. And in New York, because it was a massive inpouring of patients into our acute care settings. So that meant, not only finding additional space, which now we are, obviously, you've seen the data, we're basically back at capacity in our regular buildings. So way fewer sort of tents or offsite locations, and actually have been able to redeploy, physicians were taken out of their ambulatory practices and working in the buildings back to their regular practices. But it is all of the things related to how would you use technology to newly train that workforce, to understand where patients are in the building, and in order to care for those patients. So prior to COVID, we leveraged telehealth quite a bit to bring specialties across that member 23 hospitals, meaning whether you were talking about a tele-ICU, so you would always have an attending with the ability to cover a case even in a tiny community hospital, or psychiatry, which tends to be a specialty in high demand, so that you could have psychiatry anyone wanted it on telehealth. With COVID, that to everything because the resources were low. So how do you use technology to expand your ability to provide care? And then sort of rapid adoption of kind of bring your own device, which is I have a device, I've just left the hospital. How are conversations happening in that device? How are we using that device to kind of to educate patients? And then again, using that same technology in these post-acute provider locations. So how do we provide support to a SNF, a skilled nursing facility or rehab or a group home, where we are mitigating the infectious component by being off-site, using telehealth to provide the clinical expertise to that facility. And then I think also, one of the other things was around using telehealth to connect families, right? So how do we, in a PHI way, connect families that are now not able to come into the hospital building because of visitation restriction, important visitation restrictions, but still keep families connected. So that was also very important. Kind of launched into the utilization of Microsoft Teams, and I will hand it over to Max Kaluuya, who is our senior program manager, and important in terms of launching these communication pathways, because once you have a new workforce and a new disease, really understanding what is the technology you have to follow these patients clinically across space and time, and then feed back to the clinicians what's happening with them. So I'll turn it over to Max.
Hey everyone, as Dr. Brown mentioned, my name is Max Kaluuya. I'm a senior program manager with our Health Solutions' Transitional Care Management team. So my team was tasked with assisting our hospitals and inpatient facilities with triaging some of this massive volume that's coming into all of the different hospitals. So our team is a team of about 75 clinicians, from nurse practitioners to registered nurses to resource coordinators, and we are deployed at every single one of our 15 hospitals all throughout the health system. And so we needed a way to quickly get our team members to communicate with all of the different physicians and inpatient teams that are seeing these patients, both in the emergency room and in the inpatient facilities. So we leveraged in Microsoft Teams. It was something that we had started to roll out a little bit before the whole, before COVID, but we were really able to ramp it up and get it on everyone's device. And really start to get everybody to utilize this program as quickly as possible. It's a Microsoft device, and it allows basically for both chatting from like a person to person, also video conferencing and holding meetings, very similar to what Zoom is allowing for us right now, but then also for PHI secure transfer of information between different teams that could be including an inpatient team that also includes some of our care navigators and administrative folks. So it's very provider driven. It is, so when in our specific workflow, when a COVID-19 case was identified by an ED provider that was at risk for a hospitalization, that provider was then able to chat with our team member to say, this is a patient that's in the ED. We suspect that this patient is COVID positive. We want to discharge this patient. Can you follow up with them afterwards? And so that allowed the provider to discharge the patient to either home or back to their facility. And that would allow our team to then take that case, enroll that case into our care navigation program, follow up over the phone, and manage that patient at home with either telehealth visits if needed, with routine follow-up phone calls, and really care management to understand what the patient needs to keep them safe at home while they're dealing with this. So Microsoft Teams was a very, very important tool that we were able to get up and running with all of our different hospital partners. And each hospital now has a team that operates and uses this communication pathway. So the way that our teams adopted Teams very, very quickly and very succinctly really helped us manage a lot of the logistics around communication during this crisis.
Great. Thank you. Is my volume still on?
Yeah.
Awesome. So the navigation services that Max was alluding to, so it is all of these kinds of all of these symptoms that, again, over time, you are going to want to have some way to capture that information and then kind of feed that back. And our way of doing that was through MS Teams back to the providers so that they were getting real-time feedback around what was happening with those patients once they left the building. The other thing, again, this is just In terms of the provider, it's optimizing order sets and leveraging the technology of the EHRs, which is, traditionally pre-COVID, there was a great deal of effort that went into different order sets, which was no different in COVID, but the timing of modifications. So the ability to create a team, not an MS team, but just a regular IT team whose job it is to communicate with your clinical operations to understand what is the new sort of data set. So if we think back to the beginning of this, where the standard of care was azithromycin and hydroxychloroquine, and then got very quickly to a point where it was clear that azithromycin was adding nothing and potentially causing harm, to make sure that things were updated and modified, again, up to 2 to 4 times a week. And then the issues with VTE and clotting prophylaxis, making sure that those are the orders, and then our understanding of how many weeks post-discharge that was going to be needed, and making sure that through the entire patient journey, both the inpatient EHR, but then also outpatient calls, that was built in to make it easy for providers who, because this is all new, this is the first time they're managing this disease. So that became very, very important. So quickly, data analytics, and I'll wrap it up, which is at the very beginning, again, having an emergency operations center and a clinical operations team that is basically just deciding what are the important metrics for your hospital or your system. So whether that's total discharges, whether that's area deaths, whether that's confirmed, whether that's the number of total cases, because it does allow you to understand where are we? Are we on the other side of this? And also what additional resources are needed and where. So that was another deployment, which was around really matching up the population to hospitals that had capacity either or not, and without some kind of dashboarding to know where the patients are, that would have been logistically very difficult. And then predictive modeling. So this can be very helpful in terms of many different vectors. So ICU versus floor care. Can you predict who is going to do well in each of these domains? Day 1 versus day 2 trajectory of deterioration. So who are patients who, based on what we know, are likely to be the ones who are going to deteriorate and should probably start in the ICU? And then survivability, wearables and sensors. So patients basically, instead of sort of the old model of sort of being on a tele floor, are there other wearables and sensors that can be looking for these things in the background using machine learning and AI? And then utilization of beds and vents and resources. Thankfully, despite the surge, New York ended up having more than enough vents throughout the pandemic, but it was because we and lots of equipment that might not be everyone's, the situation globally. So ability to sort of predict the number of things you are going to need, the census growth, admits to discharges, all of those are important. And then just finishing up with workforce, really important, continuous communication with every modality available. So whether that is text, so at Northwell, we have a daily text, our other healthcare platforms that we normally use 365. There were multiple sort of educations and learnings. Probably every department had its own version of what we call COVID University, or some episodic installments around how we were managing COVID, both clinically, operationally, so that there was a shared understanding. It is a time of tremendous anxiety. Everything is different. It's different in everyone's domains, their home domain, their work domain. So making sure that people had access to really information, that information was coming constantly, really helped people feel connected. And then the last thing I'll just end on the employees was also establishing remote behavioral health for employees, so that if people were feeling overly having difficult time coping, that there were opportunities for those employees to be helped from a behavioral health perspective. So I will stop there, and I think we'll have questions later.
Thank you very much, Dr. Brown, for an excellent presentation. We're gonna, because of the time, we leave the questions at the end. I'll also encourage everybody in Zoom to have, the question and answer part. They can ask questions through that, and then we try our best to answer them at the end of the session. Now, we have to go with our colleague, Dr. Abdullah Raghdi, from Director of Information at Ministry of Health, Oman. Please, Dr. Abdullah, you can start.
بسم الله الرحمن الرحيم. السلام عليكم جميعا. It's my pleasure to be on this webinar, and Oman is like any other countries, trying its best to provide a proper information technology solutions against the COVID-19. I won't talk what has been there for long, but what is being built is the essential infrastructure that helps on this pandemic, such like a national electronic health record and personal health record. It really helps the country to get a proper history. I would like to touch base on what we have, especially for COVID, implemented in Oman. We have implemented a full-fledged system called Tarassud. And it is not only an applications on the mobile, it is more than that. We have built a central or a national system called Tarassud for outreach system that is more or less lab-based surveillance. So it is connected with the HIS across the country, and it is connected with the all lab analyzers, COVID lab analyzers across the country. It is also integrated with the central public health lab in Oman with its own analyzers. So all these are being put as a full-fledged system to ensure that entire system work in systematic way, fully automated rather than any hand or manual work. The Tarassud itself, it has been open for the private and the public health institutes, not only within the Ministry of Health, but it's also available for the private establishments as well as public health institutes. In top of that, to make sure that the public is part of this pandemic, we have built a mobile application. And there are many services within that mobile app, and we have built chatbots and other services such as awareness, statistics, dynamic maps, and so forth. I will touch on later with two services that is essential and try to make the public or the community safer, and also try to reduce the clinicians or health workers from the isolated people. This is one of the screens that the dashboards where it shows the numbers on the graph or on the map by governorates and by wilayats in Oman, where it gives account, directly counts, real-time accounts with the number of confirmed cases, isolated, recovered, death, and so forth. It drilled down until to the specific person with his timeline when is initiated the cases up to the hospitalizations. So that's the timeline where it gives, it reflects to the decision makers or to the clinicians the entire journey of the patients. So that is how Tarassud works, and this is one of, I think my colleague here, Dr. Abdullah, might say the same thing. We have used Bracelet for the all isolated people, and it is integrated with the mobile apps. It is integrated via GPS as well as Bluetooth. So all isolated in Oman are being given a bracelet to be wear, and that is tagged with the mobile app. So whenever he goes outside the stations, I will show this screen. Whenever he goes out, for example, if you see the other side here, the screen bottom at the bottom, we can tackle where he been, this guy, and whom he had met. So we can identify all those violated and been out during his isolations. There are different dashboards where it reflects all violations people against the isolation rules. In addition, it alerts all the public through the Tarassut app whenever there is somebody on the sides, will be alerted on his mobile. If you allows me, I will show it in a quick that if anybody, sorry. I hope you are hearing this voice.
No, we can hear
Do you
it.
hear this voice, guys?
Yes, yes.
Yeah, that is because the bracelet is just beside me. So it gives an alert down here that somebody next to you as a COVID person. It gives you an alert that somebody just beside you. So this is all the public will be run away, and the authority here will be called these persons, and it might be fined as well. The other services that we are still, it is not implemented yet, but we are in process that we are building up. This application will be given to the police as a checkpoints. So the police will take the pictures, and if he's an isolated, that will be none. This is an isolated people. So in all checkpoints that can be identified directly and can be seen where he has been out and why is he going to the hospitals or he's going somewhere else, the police will take care of. The other device on the left side here, that is going to be kept in all the shopping malls or any institutes or even in the mosques. So if anybody isolated, this machine will be ringed directly, so everybody will be noticed that somebody from the isolations or infected person will be, he is in that area, so everybody can take care of. One other thing that we have built is Medical Scout. This is actually self-symptoms reporting. We have built an AI on top of these symptoms, so the isolated person will be using the app as a chatbot. He can daily record his symptoms. According to his recording, answering all the questions, the AI will classify him. What is his risk? Is he in high risk or in a medium risk or no risks? So the governors or the institute will be in contact directly with these patients. So there is, and the next day, according to his symptoms, will be following up his cases. So that is one of the good services that we have built, and to ensure that we are also protecting the health workers from visiting the houses of isolated or any other places. We have also run a virtual clinic. It's part of the personal health record. So the doctors, some of the clinics are being stopped from the hospitals, stopped in terms of physical visits. We have altered to virtual clinics. So that is also in place. We have used the drones for temperature detects. We have used the video conferencing that to ensure a social distance. We have also provided a delivery healthcare app to home to the patients using 2 different apps from 2 different providers and WhatsApp as well. So the patients, rather than coming to the institutes, we will bring or we will deliver the medication to his house. On top of all these, we have also built, unfortunately, I didn't put the what do you call it, the slides, but in top of that, we have also having a business intelligence system as a national dashboard where it reflects all the available beds, whether it is in ICU or in any other institute across the country. That is in a quick what we have built so far in Oman.
Thank you very much. Very
I
interesting.
hope I didn't take much time.
First of all, well done on Sultana, Ikhwan of Sultana ما قصرتوا. You presented really a great presentation and great effort. I mean, this
Thank
is
you.
state-of-the-art way of doing things using technology, and really appreciated that you shared with us your experience. Now, because of the time, I'm gonna go for the next speaker. We have Dr. Abdullah Sane from Kuwait, Ministry of Health. Abdullah, can you hear me?
Yes, I can hear you very well.
All right.
Okay, let me just put my slides. Okay, can you see it?
Yes.
Okay, hello everybody. Assalamu alaikum. Excellent job, Oman. Pretty much we are doing the same, but you are ahead of us. So let me show you briefly what we did. So we developed an app. It's called SHLONIK. Now, mainly it was done because we have 60,000 Kuwaiti nationals all around the world. His Highness the Emir wants to bring them all to Kuwait, and we thought that it would be very difficult to bring 60,000 people at once to the country without monitoring them. So in 12 days, we came up with this app. It's called SHLONIK, and it's, again, as you said, in Oman, it's based on a bracelet and an application on a phone. It's a Bluetooth technology. So the app is meant for everybody and for quarantined individual in particular. So if you see, upon arrival from the airport, we download the app for them, register them, and let them wear a bracelet. And then once they go home, they create a geofencing around them. So this way they cannot leave outside their houses. Every day they have to prove that they are in their homes. So they have to take a picture, a selfie. And with the bracelet, we can make sure that they are still wearing the bracelet and in their homes. And this is done by a selfie, a picture, or by voice. So a voice print. We can send them a sentence and they can repeat it, and we can guarantee that this is them. We developed also a telehealth. So a doctor would be on the app waiting for the questions if they have or concerns or symptoms. For the general public, like you and me, we don't wear bracelet, but we have to develop SHLONIK, and it will give us information about the virus, prevention center numbers and locations, social distancing information, latest updates, and a bot, a COVID-19 assessment agent, like you said, in Oman. So once people came from the airport, everybody received a bracelet. They're actually happy about it. They're very cooperative. We delivered so far 26,500 bracelets in the airports, and we're getting these bracelets from factories from China. And right now we have in our stocks 100,000 bracelets. Once we sync it to the app, it would say the bracelet is registered, and this is the code number for it. Now, in order to make sure that they are at home, they get notification through the app that they should check. If they don't reply, they get an SMS within 5 minutes. If they don't reply, they get an automated phone call, and then an agent in a call center will call them and make sure that they would comply with the instructions. If, let's say, the person is asleep or taking a shower and he didn't do all these steps, someone visit them at home to make sure that they are at home. Otherwise, police car will come and take them to an institutional quarantine with a lawsuit after the jail or a fine, a hefty fine after the pandemic is done. Now, these are people who registered, downloaded the app. Mostly people all over the world, they want to come to Kuwait. So our target is to bring all these blue dots back to Kuwait. So far, we have 26,682. The red dots are people in quarantine. The blue dots are just regular people who wants to download the app. Now, the most important feature I find from this app is Bluetooth technology. So when we ask somebody who's positive, who were you in contact with in the past 10 days, nobody knows. They would tell you immediate contact family, but they wouldn't remember, and they would ask to give us their phone and see who did you call, maybe it would ring a bell. Now with this technology, you can actually trace back contact like this. So I can say Fahad is in contact with Abdul Latif at 5:53 on this date, 20 meters away. Or Munira and Awatif, half a meter away on that day. This way we can assess who is a potential contact and we can apply the same rules of them or not. So people are starting to download this app to protect themselves and protect other people too. Now I'm gonna skip through the slide. We're gonna do the same thing. We have telehealth capabilities as well, appointment scheduling through the app. Now, this is a funny part. People are interactive with this app, so they send selfies every day. One guy is sending us pictures and messages every single day, and he's very funny. He's the most famous quarantine person in Kuwait. Now, it's not necessarily a bad thing. People are really reactive to this. And that's my presentation. This is what we did so far in Kuwait.
Thank you, Abdullah,
Excellent.
for an excellent presentation. So again, so we started with New York and the impact of coronavirus in New York, and then we went to the GCC countries, our colleagues in the Gulf, with Dr. Abdullah Raghdi from Oman, then Dr. Abdullah Sana from Kuwait, and now we're going to go to Kingdom of Saudi Arabia. We have our colleague from Saudi Arabia, Mr. Muhannad Jamil, who is the General Director of Health Supporting System and Ministry of Health. Kingdom of Saudi Arabia. Muhannad, are you with us?
Yes, I'm with you guys. Can you hear me?
Yes, we can hear you.
Yes, okay. First of all, good job, everyone. I'm sure this is a hard time for everyone, and everybody is doing their best. And first of all, my name is Muhannad bin Bali. I'm the General Director of Health Supporting Systems. I'm handling most of the supporting systems that's out of the EMR and the telehealth projects. First of all, I would like to thank you all for giving me this opportunity to present the way that eHealth at Ministry of Health responded to the COVID-19 pandemic. Well, unfortunately, the healthcare sector is in the front line to be face-to-face with this crisis. And we are, as the enabler party, we must support our medical team and arm them with the best tools and data that would be helpful for this pandemic. Let me just share my screen. Can you see my screen?
Yes, Abdullah, we can see it. If you just can expand it.
Okay, good. Well, first of all, we started to have we built up a team that will support the, sorry about this. We started to build up a team who's going to be responsible for the, coming up with the analysis and the workflow, who's going to support the team in the command center in our MOH, National Command Center. Their job is to analyze the workflow, identify the required data that get the systems and apps needed for the pandemic. Then after that, we immediately built up a dashboard that connected the required data through our national observability, which will help having a vision of the clinical capacity throughout the kingdom. Then we started to use all type of of the media, including social media and telecommunication providers, to send in awareness and education messages to the public and in different languages. After that, we started to build up our digital applications. We used many digital applications. Some of them are already here, are already there, and some of them are new and introduced during the pandemic to support the situation. Then we had some cameras installed in our hospitals to monitor the hospitals closely. Let's elaborate more on the mobile health support systems that we used. We had a consultation, our consultation channels. We have our Sahha app, and we have our 937 phone number, call center, and we have the centralized appointment system, which we call it Mowed. The Sahha app, from March and April, we had around 300,051 consultation, and also in total with the 937, we reached out just April. We reached out to 1 million consultation, helping everyone throughout this pandemic, and make sure that everybody can be relaxed and everybody will ask questions and make sure that we are in a good health. And then after that, we added a COVID-19 self-assessment in our public appointment system, Mowed, because of the large popularity within that app. We had around 964,000 assessments has been made. Out of it, we had 18K suspected cases, and these suspected cases will go through the process throughout the process to confirm whether if it's positive or negative cases. After that, we had a virtual clinics and telehealth to support the pandemics, because we are very certain about the continuity of care, because as you know, most of the clinics are really closed, and nobody is going to hospitals for their appointments. So we used some quick wins using Microsoft Teams, and we had a very full platforms through our Sahhati app, which is our unified platform, which has which we had the appointment system, we have the prescription system, we have the applications, the medical application systems. All these are within that app. Also, on that app, we introduced the video conferencing that will support the virtual clinics and appointments. Also, we had the robots technology within the telerounds to make sure that all these doctors are doing their round visits without any physical interactions with the patients. In regards to the PAC solutions and X-ray radiology solutions, we built up a platform on the top of our existing PAC systems, connected on a central solutions with an AI solution that will to support the CT chest examinations. Then we had the Taqassi platform. Taqassi is a platform to unify all process access the region across the regions. It's the only source of truth for the confirmed cases. It built up reports to confirm and for confirmed and suspected cases, and monitoring the quarantine or home isolation. Also, the platform mitigates the risk of the virus public spread, and throughout several dashboards and suspected respected graphical demographical with the help of decision makers to help the decision makers to take the right actions. The policy has a lot of different process to get the patients registered. First, we have to register the suspected cases. All the suspected cases direct into the required actions. Direct all the cases to the health facilities for the testing. Update the health status based on the test results. Recover the extent follow-ups. When the hospitals or the isolation or quarantine follow-ups through doctors, through calls or through the tele-rounds. Then after that, the investigation of the confirmed cases. Then we have the Tatamman app. The Tatamman app is the application which works under our National Health Emergency Operations Center to commit all the arrivals to the Kingdom of Saudi Arabia from outside of the country, and make sure they register their residents and enable the continuous of communications and follow-ups within the isolation. This will support the decision maker through the statistical information and performance level, alongside with the efforts of the various parties to contain the crisis. Thank you so much for your time, and hopefully I have managed to demonstrate all the efforts that has been made during this pandemic.
Thank you, Mohammed, for an excellent presentation. With that, we have all our speakers gave their talks. I would like to congratulate all of you for the amazing work that's been done in a very challenging situation that we have with COVID-19. So we have questions also from the audience, but I will start with a few, and then we'll go and ask and answer some of those questions. First of all, COVID-19, it seems it's been a booster for our systems around the world to use technology in digital healthcare. And with that, boost, I think there is multiple stakeholders involved. Like I can see in one country, for example, there is multiple solutions, multiple stakeholders, multiple organizations, and so on. I mean, this is also in terms of change management. I think it's a difficult and challenging. How did you approach that in your institutions? I mean, this is an open question to everyone in the panel, and how you decided and how you incorporate those solutions together.
I apologize. Can you repeat the questions again? So
can you hear me?
Yes.
Okay. So we know that with the COVID-19, it acted as a booster for technology improvement and adoption in everywhere in the world, it seems. And I think it's a good thing. It's been acting as a booster. But with that, we are seeing there's multiple solutions, multiple platforms in each country. And in terms of change management, how do you think about having all these solutions? What challenges you're facing with having multiple solutions and platforms in the countries that you're working in?
Well, from my point of view, whenever you have a vision, it can be achieved. So within a short period, with our challenge we have faced is just an example of our system is to build a scratch system in 7 days. That's a big challenge. And integrating all these technologies together into one platform, that is another challenge. Is not an easy. I remember sometimes we leave the office around 12 a.m. So the good thing, if everybody is cooperated, is an easy to integrate entire technology. Is the most important thing is to identify what you need. definitely there are many platforms, many technologies across the world, but if you see globally, most of the innovations and the technology, it leads to the same post. So what you need is to identify, and then you act according to these identifications. That is my point of view.
I would, hi, it's Dr. Brown. I would add to that one of the important pieces is that it will never be that everybody will be on the same technology. And companies innovating and doing things differently to make sure that the maximum number of people are solving problems. But an important step is ensuring that the information from one technology can move to other technologies or be consumed in a non-technological way. And the thing the example I'd use there is there are probably 10 different patient-facing chatbots around COVID just in our area. But the ability for that information that's being collected potentially in different ways, some using Bluetooth, some not using Bluetooth, but for that to land in some clinical place that then allows the patient and the provider to use that information, that becomes the normalizing step clinically, where the information is gathered from the patient or using the Bluetooth technology, but then is convened in some way that always ends with that patient provider kind of relationship, and that's where the intervention is going to happen.
So, I mean,
which is very important is how sorry to interrupt. It's very important that you have to make things as most automated as you can to reduce the human interventions. So during the pandemic everybody are busy, they don't have a time, and everybody are in panic. So having multi-channels fully automated, that will serve the purpose of managing the crisis.
Okay, so if there's any more questions or answers from the panel, please join in. But so I have another also question that in terms of reopening, when we think about, when we have the curves are getting better and we're ready to reopen, do you institutions or countries have any technology that you think will help with that reopening?
Thank you, Dr. Salman. For us, is the implementation of the virtual clinic and spreading the implementation and the rollout for the virtual clinic is something that we must consider even after after reopening the country, and because this is a technology, or this is a service that helpful, and it would reduce time consuming, and it would reduce also economically it's going to be successful. So one of our successful technologies that we use and is going to be continuously to use is our virtual clinics to make sure that the continuity of care is going to be adopted in a very good manner.
Okay, I can say something from Kuwait. Now, if you want to reopen a country, you have to trace, test, and isolate. Now, we're starting with this app now, SHLONIK. We are going to try and make it for all. Everybody should download the app. Everybody should test. We should trace everybody. We should isolate whoever is potentially infected. This way, once you have a status, whether this person is sick, this person is suspected having a virus, or this person is clean, then you can slowly open a country. But you cannot do it without technology. This is what we always say here. You have to do it with technology. I urge everybody to download similar technologies and work with them and make sure that we can fight the virus through technology, not just medicine.
Right. So, I mean,
also add what you were saying before about it is a moment in time to kind of add to that. The way that people are now even expecting patients to interact with healthcare has changed. And, you know, to your point, it leveraging that and saying like, yeah, in the old days you used to X, but now it is all going to be done. 90% of it will be done remotely, and we will only be doing 10% of it in person, which is a reversal of what we've ever done. So really using this moment to reframe everything, because culturally and in terms of culture change, people are very receptive to that message. So using it as a moment where historically it might have been very difficult to get people to adopt technology, especially as it relates to their healthcare, this is an opportune moment to sort of say, in order for us to reopen, you know, to the point earlier made, our ability to have this information is to interact with you as a citizen or a member is paramount, and we have to do it in these technological ways. So I think the moment is right for that transformation.
So I have two questions. One is about privacy and patient confidentiality with all these apps and technology. And the other question for the GCC colleagues, I mean, do we can have in the coming days or months APIs that so we can integrate our systems together? And if yes, I mean, it needs another session by itself, but just as a booster for future, if we're talking about reopening, I think we have to think about how travel process will work. And if we have all these platforms, how we can integrate with APIs.
Well, thank you very much. I think if we talk about security and privacy and confidentiality, I think each country will have its own privacy and confidentiality laws. But in terms of securities, that's in Oman, for example, that we are encrypting all the data through the transport layer security. And we do penetration testing to ensure that there is no vulnerabilities. In addition, we are also using the DDoS attacks. So secure, secure reverse proxy as well. So we are trying to build as much as we can to ensure those data are confident, stored within the premises of Ministry of Health. We are not hosting any data outside the country. It's all of health data is within the Ministry of Health and fully protected through different technology. It is based on a privilege granted to each users. Again, with your previous questions you have asked after opening, I think the pressures on IT is much more after opening, the scenario of opening. The pandemic had shown that how important IT is. So we have to work too hard, especially the life or the workspace might be changed from physical work to a remote work. We should also think about pharmacy drive-in, for example. We have to adopt AI. Currently in Oman, we use AI for chest classifications, for breast cancer, and we are also piloting for retina. So all this, but the next days, I think the pressures on using AI, using the blockchain or using the big data, it becomes essential to work on. With regards to the cooperations with GCC, I think the possibility always is there. What it needs is more understanding on each country's need, and with the cooperations that can be done, definitely.
Okay, thank you, Abdullah. anyone from the panel would like to have his input on these questions? Can you hear me, or I think some of the speakers are muted.
We do hear you.
Okay, so because the rest of the speakers, I can see them, they are muted.
They are getting prepared for iftar.
Yeah, so you know, we tried our best to answer some of the questions from the audience. It's given me great pleasure to moderate this session, and it was a very interesting session. We learned from it, and I hope that we continue this kind of collaboration. And I think with this kind of collaboration, we can even help our nations and work together and try to give the best that we can give to our nations from care, from technology. And at the end of the day, I mean, we can utilize, unfortunately, this very challenging time to boost our technology and digital healthcare in our countries. Again, I'd like to thank Siviltana, who's behind the work about this platform and Zoom and all the communication she's been doing. I would like to thank my colleague Osama Al Hassan from Emirates for his great ideas and support, and also all the panels, Dr. Abdullah Sana, Dr. Abdullah Raghdi, Akhui Mohammed Jamil from Saudi Arabia, and Dr. Brown from New York, and Masoud from New York as well. Thank you all for being here with us, and we wish you all the best. Be safe, and we look forward meetings and webinars in the future, inshallah. Thank you.
Thank you so much.
Thank you.
Well, thank you very much.
Thank you, everyone.
It was our pleasure to hear from all the experience from different countries, and I hope the cooperation is not on virtual. We would love to see it on physical. And I will take, if you don't mind, I will take the last questions. Somebody has mentioned whether EHR helps on COVID. Definitely it is, because we need the clinicians, they need to have a proper history back of the patients, where EHR can help on that. So wish everybody Eid Saeed, inshallah. By the way, my name is Abdullah Al-Raqadi, not Al-Raqdi. So thank you, Dr. Salman, for your moderators, and wishing everybody happy days.
Happy days.
Thank
Thank you.
you.